Hello everyone. So this is our fourth and last case of our case series for deteriorating patients on the ward. So this patient is a 47 years old man with a history of alcohol abuse and still drinking currently with cirrhotic liver disease and esophageal varices with previous bleed treated with banding. He's a smoker and he has a defunctioning ileostomy done 10 months ago for bowel obstruction. And he's depressed. So he presents with 3 days of abdominal distension and pain, with large volume hematemesis and bleeding from the stoma. So he's basically vomiting blood and he was bleeding from the stoma. He had a massive transfusion, then he was stabilized with no further bleeding. And then he was transferred for investigation of source. So what's your differential diagnosis again here, and what investigations are you going to perform and why? So again, differential diagnosis means take a step back and try to think broadly about what could be going on here. So I mean, the story here is quite straightforward. The patient, we know, has a cirrhotic liver disease with varices. So and the presentation was, massive bleeding. So clearly, it's quite in this case obvious that the patient is presenting with, massive hemorrhage and was bleeding from the bowels, either from upper or lower, gastric bleeding. Anyway, how would you approach this patient? And do you think that this patient might need a higher level of care? In which case, can he go to the ward really, someone like this? Or is he going to go to the HDU or the intensive care unit? So, before thinking on where to go, the first thing to make is, obviously a diagnosis and then investigate exactly what's going on here. So again, as I said, whenever you see a patient who's deteriorating rapidly, everyone is rushing there, but you have to stop, take a step back, and go back to the basics. So you look at the history, and the history here. You know that the patient is an alcoholic with a liver disease, with varices, and with a history of bleeding, and he had a stoma with an ileostomy for bowel obstruction. You might want to have an accurate physical examination at this stage. You want to review, the patient from top to toe, from, all the systems. You want to look at the cardiovascular, respiratory, kidneys, the liver, and neurological here. You want to take labs because the patient is presented with massive bleed. So obviously you might want to take the basic labs, FPCs, coag, UNEs, LFTs, etc. And you want to perform investigations. So okay, I'm not gonna go into all the details of all that because that's not really the scope of this lecture or of this presentation. So that's the relevant labs that we have here. HB is 8.4, platelets 98. Okay, INR is 2.8, etc. So from here you can tell that the patient has bled because HB is lower than normal, so we have anemia here. But again, I was mentioning, as I was mentioning to you in a previous lecture, HB is not always a reliable indicator of acute bleeding because when you have an acute bleeding, so the patient is losing 1 or 2 liters of blood, for example, just to throw an example there. If the patient is losing 1 or let's say a couple of liters of blood, and it's acutely bleeding, the hemoglobin doesn't really change. People have the misconception that hemoglobin drops while the patient is bleeding. In reality, hemoglobin is actually a measurement of concentration of hemoglobin in the blood. So it's described as gram per deciliters. So it's a measure of concentration, not a quantity of hemoglobin. So if you have a patient acutely bleeding, the hemoglobin does not drop immediately. You might take a blood sample while the patient is bleeding, and you'll discover that the hemoglobin is actually normal sometimes. You can imagine this concept by trying to picture a bottle of saline, for example, a liter of saline, where you have a certain concentration of saline, okay, of 0.9%. Let's give the example, 0.9% saline, If you take half of the liter out of the liter, the other half will still have the concentration of 0.9%, because again, it's a measurement of concentration. And same goes for the blood and hemoglobin. So if you take, half of the blood out of the system, you still have, the same hemoglobin, because it's a measurement of concentration. Now, hemoglobin starts to drop when you start to resuscitate the patient and you start to infuse fluids in the patient. So the patient is receiving fluids that do not contain hemoglobin, obviously. So hemoglobin concentration starts to drop, and that's when you see a drop in hemoglobin after you start giving fluids. So that's all of that, just to say that do not always only rely on hemoglobin to see if the patient is bleeding, because sometimes some people call you on the ward, they suspect a bleeding there because, so for example, a ruptured spleen, internal bleeding, you don't really see it. You take a sample of blood and you see hemoglobin is normal, and you can, come up with the conclusion that the patient is not bleeding. So that's a big mistake and a common, misconception. Do not rely solely on hemoglobin to, define your diagnosis, whether the patient is bleeding or not. So anyway, the patient here is bleeding, is being resuscitated with some fluid, and hemoglobin has dropped. Platelets are lower than normal, and that's because, he tried to coagulate there, and he's consumed some platelets. The INR is elevated, and this is most likely related to his liver dysfunction there, okay? So INR is high, patient is basically anticoagulated, and has bled, most likely from the gastrointestinal tract. So whether it is coming from the upper GI or lower GI, that has to be discovered by more investigations. And that's why in the basics, you have to do history, physical examination, labs, and investigations like imaging or similar things. And here, the gold standard for this kind of conditions is an OGD. Here the surgeons perform an OGD and try to identify the source of bleeding that, you might think that, most likely source of bleeding here is esophageal varices. So they perform an OGD and they find that it's normal actually in this case. Patient has no varices there, major ones at least, or they're not bleeding acutely. So, the bleeding is not coming from there. Here on the side, just for reference, there's a OGD with varices. You can see the difference. It's quite obvious. So anyway, in this case, the patient is not bleeding from the upper GI. So more imaging is required, more investigations, and so we perform a CT angiogram. And at the CT angiogram, we discovered that the patient has mesenteric varices. So lower GI, and he was bleeding most likely from there, and that's why he was feeling, the stoma bag, or he was bleeding from the stoma, because actually the bleeding was coming from the lower GI. So anyway, that's how you go, to define a diagnosis. You start with the basics, and then your investigations will complement all that, and you will most likely, most often you will find your diagnosis. So anyway, we transfuse the patient. The patient has been stable for the last 3 days. After admission, and initial transfusions, he was a bit confused, and that's usually a combination of things. A combination of the hemorrhagic shock. That the patients in shock do not perfuse very well the brain, and if the brain is not perfused, then the patients don't think very well. So they're confused, agitated sometimes. So could be the fact that he was under the effect of, some alcohol or, liver dysfunction, etc. So, multifactorial confusion anyway. He's been transfused a total of 4 units over the first 2 days. He's settled by the end of day 1. He's eating and drinking, and the stoma is working there. No further bleeding. HB is stabilized. Although, the source of bleeding was not, controlled by intervention, or either interventional radiology or surgery. The bleeding just stopped, and so, he was stabilized. But the problem here is that coagulation remained abnormal because, you have a liver dysfunction on the background. So unless you treat that, you will still have proclivity to develop, coagulation abnormalities. So anyway, the patient remains, despite treatment, abnormally anticoagulated. And on day 3, patient is stable enough to go back to the ward. So discharge has been decided, and patient, we remove the arterial line from the patient. We leave the central line there. Perhaps it's a combination of, maybe we just leave the central line just to see if he requires, resuscitation later. We might use that. or further transfusions. So anyway, patient is waiting for the bed on the ward, and during the round, the HDU nurse, oh, by the way, the patient was transferred to the HDU, obviously, because, after a major bleeding, you might want to observe the patient for a couple of days, and he was there, he was doing fine, and then eventually was going to be discharged. So at some stage, the HDU comes back to you and starts to call you because the patient has the stomach bag full of blood, and the patient is cold and clammy. So those are the vitals: HR 135, blood pressure 76/45, saturation 87 or Romer, and the Glasgow of 13. So what is going on here, and what is your plan? Now, when I told you that, when you have a patient who's deteriorating, try to find the time to take a step back and go back to the basics. Now, this is one of those situations where actually you might want to probably rely on your clinical judgment and your experience and your intuition here, because you don't really have much time to go back to the basics and review all the details of the background or labs or perform labs or even investigations here. The patient is quite bad here. It's quite rapidly deteriorating. So this is one of those situations where you kind of have to rely on your clinical judgment and on your intuition. So I think you all have already understood what's going on here, and it's quite obvious. The patient is filling the stomach bag with blood, cold and clammy, and those blood pressure and heart rate. The patient is having another hemorrhagic shock. So yeah, sometimes you just have to rely on your instincts here. So what is your plan? How do we go from now? Now, first of all, why is this relevant? Okay, why is an hemorrhagic shock relevant? Why are we concerned about this? And you go back to physiology here just to catch up with basic physiology, because it all makes sense when you go back to the basic of human physiology. So this is the oxygen supply demand graph, and you have your oxygen delivery on the X and your oxygen consumption on the Y. And you know that in a normal patient, your oxygen delivery is usually 1,000 milliliters per minute, and your average oxygen consumption is around 250 milliliters per minute. So that's the blue line here. On the far right, it's the normal patient. That's where the normal patient sits. Now, when a patient starts to bleed, you will start to observe that the line starts to go to the left because you are decreasing your oxygen delivery. But your oxygen consumption stays relatively stable, because again, your oxygen consumption is around 250 and you have like 750 mils of reserve. So yeah, your oxygen delivery is decreasing, but your oxygen consumption stays the same. Until a certain point, which is called critical oxygen delivery point, where further decrease in oxygen delivery is met with a decrease in oxygen consumption and an increase in the production of lactate. And that is because, obviously, when your oxygen delivery is less than the oxygen extraction capability of the tissues, then your oxygen consumption will decrease because there is no money in the bank. So the less oxygen delivery, the less oxygen consumption. And then you start to have an anaerobic cellular metabolism, and you start to produce lactate. And this is relevant because obviously when you get to the stage, you have hypoxemia and hypoxia of the tissues. So the tissues start to die, and that's when you get that's when you go into multi-organ failure. So the tissues, all the systems start to fail. The heart, the liver, the kidneys, etc. start to fail, and then you go into multi-organ failure and eventually death. So, it's this is important to know because, again, basic equation of oxygen delivery. Oxygen delivery is given by the cardiac output multiplied by the arterial content of oxygen. So, in our patient here, he is bleeding, so he's having a hemorrhagic shock. So your HB will decrease, okay? And also your stroke volume there will decrease because your volume will decrease. So you have a hypovolemia and low HB. So what happens is that by reducing your stroke volume and by reducing your hemoglobin, you will have a reduction in the oxygen delivery. So, that's another way to see it. And it's really very interesting how, everything makes sense, from physiology down to the actually, bedside. So from here, what do we do? So if we don't stop the process, or if we don't address it, the patient will continue to bleed, and then eventually, oxygen delivery will be so low that all the tissues will eventually, start to die. So you have to start a resuscitation here. So multiple large bore peripheral cannula inserted. The patient has already CVC in place in situ, but you might want to put more IV cannulas there, large bore. And the ICU registrar is already there. Patient has been transferred to the ICU. We insert an arterial line. Why do we do that? Again, we want to monitor in real life, beat by beat, what's going on with the blood pressure. We want to have a close monitoring of the blood pressure. So we want to insert an arterial line there to have a clear indication of the changes. And so what are you going to do? What are you going to give to this patient? And obviously, I think, first thing that comes to mind is blood. You want to replace blood because the patient is losing blood, so you want to give blood. But the question here is, how does it take to get the blood from the labs, from the blood bank? And sometimes the answer is that sometimes it takes longer than you might expect, because probably sometimes the patient has not been cross-matched. So you have to do the cross-match and wait for the exact blood to come from the blood bank. But if you don't really have the time, you might want to ask for O negative blood from the fridge, and that is available readily from in all areas of the hospital usually, unless contraindicated, of course. But usually O negative blood is present and available and can be given in a matter of minutes. But again, what would you do if you don't have blood in the meanwhile? You can infuse fluids. So fluids, you can refill the system in a way that at least if you don't have hemoglobin there, you still have volemia. So you can try to address the oxygen delivery problem by addressing the volemia problem. And one thing to remember really is that the patients who are having hemorrhagic shock, they usually don't die from low hemoglobin. They usually die from the hypovolemia, from the hypoperfusion, hypovolemia itself. But you kind of have to address both problems, hypovolemia and low hemoglobin. So you start to give fluids. You start to give whatever fluids you have at hand, usually crystalloids. That's what's recommended. And then once the blood is coming, then you infuse blood. And if you want to start with O negative, you start with O negative. If you have the blood available from the blood bank, you receive those. Also, you must familiarize yourself with the massive transfusion protocol that is present in every hospital around the country. Each hospital has a massive transfusion protocol. They're always usually very similar, but please familiarize yourself with your local massive transfusion protocol. And this protocol is activated when you have massive major bleeding, such as this one. So basically you call the blood bank and you activate the protocol, and a certain number of blood units will be dispatched to you. So anyway, familiarize yourself with the protocol. It's very important. Anyway, the progression here is that the patient continues to bleed, and despite multiple units of blood, plasma and platelets, etc., the BP, the blood pressure remains very low and falls further. Because the patient is still bleeding. Unless you treat the source of bleeding, the patient will still bleed there, and you can replace as much blood as you want, but it will all be lost from that bleeding source. The stomach bag continues to fill, and you see that the arterial line will, it's flattening. So the arterial line is now flat, and the ECG is still you still have a electrical activity on the screen. So what do you think has happened here, and what are you going to do? So yes, patient is obviously bleeding, but the fact that the arterial line is flat, it's an indication that there is no output here. So there is no pulse, and when there is no pulse on the arterial line, that means that we are dealing with a cardiac arrest. So we are now at the chapter of cardiac arrest and how to deal with a cardiac arrest. So what are you going to do when you have a patient in cardiac arrest? First thing to do is call for help. And how do you call for help in your hospital? Do you know that? Actually, there is a number that you can dial from any phone in the hospital, and it will activate the cardiac arrest response team. And this phone number is usually 2222, so 4 twos, but it can change in different hospitals. So again, familiarize yourself with the actual hospital number that is the one that activates the cardiac arrest team. And When you call the number, a specific team of people is activated and they will rush in and join you and start the resuscitation maneuvers. And while waiting for the emergency team to come, which will take a few minutes, what are you going to do? You have a patient in cardiac arrest and the team is coming. It will take them 2 or 3 minutes to arrive. So what you do in those minutes? You just have to follow the basic life support protocol. So basically what you're asked to do is to start chest compression, because you have a patient who is having a cardiac arrest, and the first thing to do apart from calling help is to start CPR. And start CPR, you started with chest compression. So you activate, obviously you call for help, as you see here, you ask for defibrillator and you start CPR. You start CPR by, pushing hard and pushing fast on the chest of this patient. And then once the defibrillator is at hand, you connect per protocol. As per protocol, you connect pads and you check the rhythm, and if the shock is indicated, you shock, and if not, you continue with the chest compression. So basically, the main thing here, the main theme is that you have to start and perform chest compressions as long as needed until the help arrives and the ACLS team arrives at the scene. So push fast and push hard, and wait for help, and then check with the defibrillator if the rhythm is shockable. I will leave a link in the description on how to perform CPR, and you'll have a look on how to perform basic CPR. And again, that's another thing to familiarize with. So how to be a good team member during a cardiac arrest? So there are many different little things that you can do to help, or to avoid being as an obstacle. Sometimes when people gather around the cardiac arrest, maybe they're doing nothing, they're bystanders, but they're just observing. Sometimes it's best to leave the team some space to work and get the resuscitation maneuvers done without too many people interfering. So stand back if you're not doing something with the patient. But if you're doing chest compression, you can continue doing those, and you can continue to be involved in the resuscitation maneuvers. There will be a team leader, and you have to listen to the team leader at all times to what they say. And if you are asked to do something, that confirm that you have heard what you have been asked to do, and then when you have done the thing, just confirm it and say it back. So this is called feedback loop. So you basically have to keep the team leader informed that you have understood the task, you have done it. And when you can offer your help when it's appropriate. So for example, people who are performing chest compressions, they might get tired very soon, and usually they are swapped every 2 minutes. So offer help in that regard. You can do chest compressions and you can help, or if you're assigned different tasks, you can carry those. So essential communication only, and try to minimize the noise. And don't be afraid to speak up if you see something wrong or something that might be of help. Try to, you can say it. No, there's no problem. And you can, communicate with the team leader at all times. So anyway, you're starting your chest compression. Then the team comes, helps you out. They start to do ACLS. But the bleeding continues and the patient remains in cardiac arrest and remains there for 40 minutes. So no ROSC, so no return of spontaneous circulation. The stomach continues to fill with blood, and bleeding is most likely obviously from the previous source of bleeding, which are mesenteric varices, which are not compressible. So there's nothing much to do there. Patient is being transfused 12 units for plasma, etc. And then what do we do here? What would you do if you are dealing with this situation? 40 minutes of cardiac arrest, bleeding non-controllable. Yes, so basically we just have to call it. So usually the team leader calls the time of death, and usually there is a consensus among the team, and the CPR is then stopped, and then the time of death is called. So yes, it's a sad moment for everyone, because it's everyone is sad when this happens, and but cardiac arrests happens all the time in hospitals, and sometimes the resuscitation efforts are not successful, and you just have to accept that. So after a patient has died, there are certain other things to do. You have to, obviously, to confirm that by physical examination, Then you have to consider the family. So you have to tidy up the scene, clean up around from, all those cannulation attempts, the bloody sheets, material on the floor, etc. Remember that ACLS is an aggressive intervention, and, the last thing you want to do is to leave the patient like that after an ACLS and leave the family to witness the scene without having it properly tied up. And then you have to consider the law. Is this a coroner's case? In which case, do not remove any tubes, lines, and devices, before the coroner has actually given you the permission to do so. And then obviously, the team, usually the senior team member, usually consultants, they meet with the family. And when you meet with the family, you have to give, the bad news. And always when you give bad news, try to be direct. It's very hard to do so. It's always very hard to give bad news to family members, but you have to be frank. You have to be honest, and you have to use simple terms, and you have to be compassionate, empathetic, but also very honest and frank and direct. Don't hide behind euphemisms. Just tell it as it is. I am sorry. I have no good news for you, and your next of kin, or you call them by their name, has died. We have tried to resuscitate with all the measures that we have, but it was not successful. And then you use basically simple words, simple sentences, and you listen to what the reaction is. So it's important to get comfortable with the fact that the family will react in different ways, and you have to give the time for them to process what you're saying. So appreciate the silence, and sometimes best not to say too much. Just say the things that have happened and what was done, and just let that sink in with the family, and just let them react to it. Allow them to do whatever they need to do, cry, talk, get angry sometimes, but always leave time for them to process what has happened. And then, documentation. You have to document very clearly what has happened in chronological order. Don't miss anything. You have to document the examination, that you have confirmed that, and document the family discussion. And again, as I said, these events are never easy for anyone involved. There are always sad moments because everyone is doing their best efforts to try to resuscitate the patient, but then sometimes it's just above our science. It's just above our possibilities. So there's no really right or wrong way to feel. You might feel upset, you might feel nothing, which is absolutely normal. It's normal to detach ourselves from the job. It's just a way to to protect ourselves sometimes. And sometimes, it's hard to talk to families and to, witness their reaction. It's hard to see, family members cry for the loss of beloved one. Sometimes this experience, sometimes you forget about it after a few days. Sometimes it just stays with you. So doesn't have to be a bad thing. Just talk to someone about it. Other doctors might help you because they have experienced that. Maybe talk to more experienced doctors. In intensive care, we see this all the time. So, we have some experienced doctors there. And so, you might want to talk to someone who has experience in dealing with death and patients dying acutely on the wards. So yes, maybe talk to colleagues, and sometimes you just talk to family and friends, because, it's also good to talk sometimes to people who are not involved in the healthcare setting. They might just give you some more perspectives, different perspectives, and, just widen your horizons, and, just give you a broader view of the events, and just help you with that. And maybe just try to, find the way to get away from work, because at the end of the day, this has to be, a job. Like, it's obviously, it's not only a mission. Like, being a doctor, it's something that it's very elevated, morally, but also at the end of the day, it's part of your life. It's not your whole life. And so you just, sometimes might want to focus on some other things, just focus on yourselves, on your reading, your music, etc. Work is work, and it's just one side of your life. And if something really upsets you, about the management, or, the possibilities or the different options that might have happened, just again, talk to someone. And, if you feel very upset, just reach for help. There's no shame in that at all. Okay, guys, so that was the last lecture of our series, and I hope you enjoyed it. And I wish you the best of luck with your exams. And if you want to keep following my lectures here, I will continue to post lectures here in the future on this channel. So if you want, you can subscribe to the channel to just see future lectures. Who knows, you might find something interesting for you. So again, thank you very much for listening, and good luck with everything, and see you next time. Bye bye.